Hello and welcome to the APPNA Merits webinar, weekly webinar. Uh, my name is Danish Bhatti. I am a movement disorders neurologist. I work at the University of Nebraska Medical Center. I have a strong interest in postgraduate education, so education for residents, fellows, and physicians in general with continuing medical education. So I'm presenting today my experiences on blended medical education and how we're doing distance learning in Pakistan. And I would like to use this as an example of how we'd like to build more programs which are similar to these. And those concepts have been formalized into a project that we're calling APPNA Academy, where we would like to platform many of these projects and how we can transfer knowledge, skills, and information across borders. You can see my email address there, dbahati@unmc.edu. Feel free to reach out to me for more discussions and future projects. I am co-chair of APNA Merit Committee, which does medical education and research information transfer. So I work at the University of Nebraska Medical Center. I'm the director of the International Neurology Program, where we have been building clinical observership program. Now we have a research observership program where we take observers to do research with us and publish. And now we have also started a visiting scholars program where we take practicing neurologists and physicians, academicians, faculty, physicians from various universities across the world to come and have a very customized experience with us, which is designed for each participant who applies based on their goals and objectives. I'm also the co-director for Comprehensive Parkinson's Disease Program, where we do Parkinson's care, including botulinum toxin injections and deep brain stimulation surgery. I'm also the Associate Director for Movement Disorder Fellowship and the Chair of Neurology Residency Curriculum Committee. So I'm talking to you as a peer. This is interactive, so just ask a question. You can type it up. You can send me questions afterwards and discuss and debate. You can challenge my ideas or ask me to explain myself more on certain points. I welcome all of it. So the goal today will be to introduce what is learning and walk through some of these learning experiences. And that will form the foundation of what we call the evidence-based medicine principles of learning. And then I will share my experiences of online courses in Pakistan. So what is learning? Why the need for these online tools for education and for learning? I think the best example I've seen so far is the example from definition of machine learning, or what we call artificial intelligence. And the example or the definition basically states that learning is a series of sequentially changing generalization. This sounds very complex, but it's pretty simple and straightforward. Learning is basically taking an experience and then generalizing it to other examples, but then sequentially changing your analysis or interpretation based on further information that you gain. So what do I mean by that? For example, a medical student starts in his third year, goes to a ward, looks at a patient with tuberculosis who's basically coughing, and he generalizes that other patients who are coughing and losing weight can have tuberculosis. So he goes back home, sees his mom coughing, and thinks that mom has tuberculosis. But then when he's proven wrong, then he improves and does a sequential change in his generalization, and that's where he's learning gradually what different diseases can present as cough and how to analyze them separately and distinguish them from each other. We can come up with many such examples. My personal experience is that when I was in surgery rotation, I started having abdominal pain. I thought I was suffering from appendicitis and got panicked, got to the ER, and I was just taking the symptoms that I've seen in patients with abdominal pain who had appendicitis and was generalizing it to myself. And all of us have examples like that. And we sequentially change it to make it better. So how do we learn? How do we make these interpretation and do these generalization, and how do we make them better so that we are more and more accurate in our diagnosis? So let's look at this challenge and understand. The traditional method of learning is that I read you different concepts, or you read them in a book, or I read them out loud in a lecture, and then you're supposed to understand and reproduce that fact. So for example, this is a true description of subthalamic nucleus. that I use as a target for deep brain stimulation surgery in Parkinson's disease patient. I can go into details of where it's located, how long it is, how wide it is, what's next to it on the right and left, what separates it from other structures, and so on and so forth. And then what I expect you to do after having learned about subthalamic nucleus is to answer a question. So select all of the following that is true. Is A true, is B true, C true, or D true, which are all different facts that are being reproduced. But this is a mechanism of learning that is very common in sciences, which are more or theoretical or logical sciences, such as mathematics or such as physics. What we take it to the next step in medicine is that we take this information and make it more visual. So that is an actual 3D reconstruction of various structure in basal ganglia. And you can see that on out here on the right top corner is the axial slice of MRI that is being used for this reconstruction. And in the picture, you're seeing various nuclei on both sides superimposed on that MRI, and you see the green nucleus as the subthalamic nucleus, a light green one. And now you can see more clearly what do I mean by the size, the shape, the dimension. And now I can tell you that it's 4.5 millimeter wide and 6.5 millimeter long. It will be easier for you to remember it. You can see these dark blue leads with white patches at the end. They're coming into the subthalamic nucleus that is being placed for deep brain stimulation surgery placement. And now I can tell you better that what will be a good placement of the DBS lead and what will be a bad placement, and what would happen if it's too medial, then it can hit the red nucleus and optic tract and so on and so forth. And now when I ask you the question, which is more practical and clinical, that when placing the leads for subthalamic nucleus for stimulation, the surgeon makes the tracks a little too lateral and ended up crossing which of the following structure. And if you remember the image from back here, you can tell that the lead, if placed too lateral, will be in these fibers running down, which is internal capsule or corticospinal tract, with the answer will be D. So this is somewhat more closer to a clinical scenario, clinical situation. But what we really want to do is to see if a patient present with a problem, then can a clinician or a physician solve that problem by relating it with the all this clinical information of lead placement, the structure, the dimension, the anatomy, and so on and so forth. So this patient is a Parkinson's disease patient who's presenting for a follow-up. You thought he had good connection with him, and you're surprised that he was not coming in for a long time. He had had DBS surgery done, and his tremors initially had benefit. And now, as you try to increase the stimulation, you're seeing loss of benefit. And now you're asking yourself this question when seeing the patient: is this lead placed too laterally, too medially, too anteriorly, posteriorly? Why is he not getting more benefit out of this stimulation? Why am I not able to expand the stimulation for this patient? What structures am I hitting? So that's what we really want to do, is for a physician that is trained properly, that has done the learning, to see a patient and listen to their complaint, examine them, and make an analysis of what does this relate to and what change needs to be done to make this patient better. So what is the biggest challenge with education? Why medical education is tough? What should we change about education? And then most importantly for today's topic, why should we use online education? Why should we use these online component either blended with face-to-face learning or separate from the face-to-face learning? So the most important point for me is that teachers need real feedback. What do I mean by that? So for example, there are some of you sitting in front of your screens watching this lecture, listening to me speak, understanding concepts that I'm trying to share and make you change your approach. But I have no idea if you understood what I wanted to say and if you would make the changes or you would even know where to begin to make these changes. So this cartoon here says that I've taught my dog how to whistle, and the other person says, oh, I'm not hearing him whistle. And he says that, oh, I said I taught him. I didn't say he learned it, because he has no feedback if the dog has actually learned to whistle. And that's the problem with our students. We teach them a lot of things, we don't know what they actually learn. And that's the feedback that's missing. So I wanted to give you this idea that the perspectives can be very, very different. So this is this old story about Zen Buddhism, where two people had a debate, and one of them was blind in one eye, and the first one raised a finger saying that there is unity of everything, while the other person thought he was saying, oh, you have one eye. So he raises two fingers in respect and says, okay, I have one eye, but you have two eyes. But the other person perceived that he's saying that, yes, there is unity of everything, but there's duality of nature, there's good and bad, evil and good, and black and white, and so on and so forth. So he raised three fingers in return, saying that there is duality of nature, but then there is Buddha or God or everything else uniting the duality of nature. But now this guy still thinks that this guy is being rude, and he's saying that between two of us, we have three eyes. You have one, and I have two. So he gets angry and he raises a fist that if you said anything more, I will punch you in the face. But the other person perceives that what he is saying is that everything is then bound together by the nature into a unification, all of this, and that's why he's showing a fist. And in respect, he thinks this is a great scholar. The other guy thinks, no, he's just being rude, and I need to teach him a lesson. So you can see how different things conveyed differently can be perceived differently by other people. So the point is that if we teach today's student as if we taught the students yesterday, we will rob them of tomorrow, meaning that they will look just exactly like we are today, and they will not look different than what we expect them to be tomorrow, and be ready for new changes like artificial intelligence, machine learning, medical devices, computer assisted decisions, and changes. It will not happen if we don't change the way we're teaching our students. So, like in medicine, we love to have evidence-based medicine. We love to know if we're using aspirin in patients with stroke, that how much it is getting better, it is helping, what's the evidence for it. So similarly, in education, we're now starting to look at evidence of what works and what doesn't work. And these are the 7 principles of evidence-based for student-centered learning or students learning. I want to highlight just a few of them. So evidence-based principle number 2 states that how students organize knowledge influences how they apply knowledge. So in movement disorders, what I teach, it's important how they organize the concepts of tremor, an algorithmic approach to tremor, that we teach them that the tremors are present at rest, or resting tremor, present during action or action tremor, postural tremor, and then a postural tremor can be isometric versus isotonic, or versus sitting or standing, and so on and so forth. So as a teacher, our job is to give them that organization of tremor for them to remember those. And when they see the patient, they can try to use that organization to say if the patient's tremor is action or rest or that or postural, and then relate it to a diagnosis such that if it's a rest tremor, it will mean Parkinson's disease. So it's our job to give them that organization, and these online tools make it easier, and I will show it to you how. Evidence principle 5 says goal directed practice coupled with targeted feedback enhances quality of student learning. So what it is meaning is that the old principle used to be that practice makes man perfect, man or woman. So the point was that the more you do something, the more better you become at it. But we now understand that's not true. The problem is that a blind practice can not only confirm or consolidate your good practices, but can also consolidate your bad practices. So a practice with targeted feedback makes one perfect, and not just a blind practice alone. So the point is that a patient, a physician, or a student examines a patient with movement disorder, for example, and then makes an interpretation. It's the feedback to him on what he did right so that he should keep repeating it, and what he did wrong so that he should stop doing it again, will make him perfect. So if he keeps practicing, keep presenting patients to his physician, and getting a targeted feedback. So these targeted feedbacks can be given to the student. So rather than someone sitting giving a talk to a 100 student class, but everybody's just listening, and you have no idea what they got. The next step is to ask them questions based on what you think they should have understood, and then giving each one of them what they got right and what they got wrong is the right way of teaching, by giving these targeted feedback. And one more principle: to become self-directed learner, student must learn to monitor and adjust their approaches to learning. So it's not only important for me to teach the student, it's also important for student to understand what they're learning and what they're not learning, what they're getting right, what they're not getting right. So it's the student's personal monitoring of their learning will result in a good or a bad learning, and online tools can help them understand that feedback more actively. It used to be we will take tests for them and give them these scores, and they will understand if they have done better or wrong. But I remember from those tests that we were confused. I would think that I've done the test amazing, and then the test results will come back and I would have failed. And I would have no idea what happened. Why did I fail? What was wrong? And I had to blindly keep trying and trying to make it better. But we can make this process much more effective by giving feedbacks so that they can monitor their approaches, monitor their better performance and poor performance. So another information to understand is that online education is not easy. Using technology is not easy. Even at University of Nebraska Medical Center, in this advanced environment, three-fourths of the faculty are still not comfortable in using technology at the campus. And this study done in 2016 compared it from 15 years ago. In 2001, the technology newly came out. And in 15 years, the data has not changed. In 2001, 15 years ago, three-fourths faculty was not comfortable, and it's still the case now. Maybe because technology keeps changing, technology keeps evolving, and more technology keeps coming out. So by the time you get used to things like PowerPoint, they're already history. No new technology are out. So what we did in our university first to understand the role of these online tools was to run a short movement disorder course for our resident. It was a 5-week course. It was designed in an online system. We call them learning management systems or LMS. So this is Canvas, where a movement disorder course was created for the residents. We gave them sections or modules which were completed every week. So there were weekly modules. Each module had the same structure. The module contained required reading material they were supposed to read and get tested on and present a summary of. They had optional reading material for additional understanding. They had an assignment to complete. They had to take a quiz that will give them a feedback of what questions they're getting right or not. Each question was designed to check a concept that they get it or not. They had a discussion board to discuss with each other, a podcast, and the lecture given that week face to face was recorded into an online video that they could watch. So they could watch the lecture online afterwards to make sure that they got the concept right. The lecture slides were given to them. They could discuss with each other. Their assignment was to create a tremor map, or the assignment changed every week. So in a tremor week, the concept that we wanted to solidify by giving this assignment was to make sure that they know an algorithmic approach to a patient with tremor, and then they could discuss with each other. There were quizzes with patient videos and specific answers, and then a feedback was given on what they were getting right about the video, what they were not getting right about the video for each of those residents. And what we found that there were significant engagement. Just in 5 weeks, there was nearly 6,000 page views by these residents. So it's nearly 400 page views per resident in those 5 weeks period. That's a lot of effort. Residents really love doing these tasks online, doing the quizzes, reading up the material, and watching these lectures. There were 167 submissions over 5 weeks by various assignments and quizzes and required reading that they were completed. And there were significant discussions online. And we found that every single one of these residents improved on their score. The improvement ranged from 10 to 46%. So nearly doubling of their efficacy or understanding of movement disorder just after 5 weeks of course. It was a 44% average improvement. So they went from a pre-course score of 41% to five week later to a score of 72%. It was a statistically significant difference. We looked at the correlation of these factors with what made them better, what did not make them better. We got detailed analytics of each resident when they were submitting this, who was performing better, who was not performing well, so we can analyze and see who is lagging behind and why, when, and what factors contribute to it. We presented this information as a poster, and we did similar other things, such as we make this 5-minute neuro examination video. That's me and Dr. Bertoni, one of my partners, and we posted it online. And you can see that within a year and a half after posting it in April 2018, by now in June 2019, there are 1.2 million views of this 5-minute neuro examination. So there is a huge interest in doing these online educations and trying to learn online. There are 1.2 million people looking up for neuroexamination videos online to try to find a good source of information. This is the current generation's desire to do. So how did we translate it into Pakistan? What we did was to develop a much more comprehensive 6 months long online mini fellowship in movement disorder. I have been running it for 3 years in a row. It's 6 months long. I invite applications in March and April. I review them and decide which participants will be selected in May. It's a small group because I have to give them targeted feedback and monitor their performance every week for 6 months. So it's a long commitment for me. And I take anywhere from 10 to 15 candidates every year. This is a third year. Third batch is going on right now, which has 9 participants this year. The first two batch completed, of course. In the first two batch, we took only neurologists, so people who have completed FCPS in neurology, a fellowship in neurology, or were finishing it, about to finish it. But this year, we have one psychiatrist, one physiatrist or rehab physician, and one internal medicine doctor with some background in neurology, in addition to 6 other neurologists, which are doing these courses. This came about after my dissatisfaction with online lectures. So I started going to Pakistan in 2015 and giving lectures to these large audience, which looked very excited. They were very interested, but I had no clue if they're remembering it or not. I had no way to follow up with these people after that 1 hour lecture. There was no continuity of lecture. Even if I go there every 3 months and give a lecture, I had no way of knowing if it was the same participants or if it were different people. I started doing skill transfer by hands-on workshop, which were longer. It was a 3 to 4 hour of training of doing a workshop with patients or with dummies or for botulinum toxin injections and other skills. But still, I wasn't sure how much learning is actually happening. What are they retaining? Are they going to follow up with my next workshop? Can I create a series of workshops to teach them or not? And I was just not happy with it. So I proposed, let's create this online mini fellowship. First year, I had to do it in Google Classroom, which was a free tool, which I still use, and it's very effective. But this third batch that I'm doing it is from UNMC's official learning management system, which is Canvas. So I'm presenting it through the Canvas platform this year, but the last years were through Google Classroom. The idea is very simple, is to create a course similar to the course you saw for my residents. So it has modules. Now there are 12 modules rather than 5 modules, and each module is given over 2 weeks period rather than 1 week period. And so I can put in more information in each module. Each module covers a specific part of movement disorder. It's designed to cover a course curriculum that was written up to cover 6 months mini fellowship. Again, modules have things like quizzes. They have recorded lectures, not one lecture now. They have anywhere from 2 to 4 lectures for every modules to watch. They have quizzes to take, and the quizzes can be anywhere from 10 to 20 or 30 questions that they have to do. Quizzes are more of a formative feedback. At the end of the quiz, they understand what concepts they're getting right, what concepts they're not getting right, and I can then score them and see which questions they're getting right and where they're having problem. There is online discussion that happens. So I use Slack platform to have online discussion. And in 1 year, last year, for example, this year is going on right now, but last year we had nearly 2,000 posts of discussion in 6 months on Slack, where we were sharing articles, algorithms, we were sharing case discussion. You can see channels on the left, starting from case discussion, learning, which are my Twitter feeds, journal, lectures, emergencies, quizzes, various different topics are being discussed in various different channels, separated out for discussions. And there could be a thread, as you can see on the right, that you can take a specific case and then make a thread and discuss it in detail. So this was an upgrade over something like WhatsApp that I have used in the past for discussion, but then I can have no way of separating our discussions into channels or have a thread of discussion on a single case, which is possible in Slack. This year, I'm still using Slack for the third batch, but what I've done now is that I have made some channels more continuous, invited the previous alumni to join those channels, such as Journal Club and case discussions, where there will be an ongoing discussion for the rest of our life. We will keep on discussing cases and movement disorder for the continuity of learning. They were given a certificate of completion. The certificate was from University of Nebraska Medical Center. The certificate gave them 60 CME credits to complete the course, and also a course completion certificate was given from University of Nebraska Medical Center. The certificate, as I said, they have received it for first 2 years, and they will also get it for the third year now. And what I also did was that at the end of the 6 months, for the first 2 years, that I did a 2 day of training workshop where I went and did a training camp only for these participants who completed the 6 months of online education to solidify their concepts with hands-on skills practice for Botox and DBS, for movement disorder rating scales, and also seeing live patients in the clinic. This is the first batch that we graduated in 2017. And this is the second batch that we graduated in 2018, and the third batch of 2019 is going on right now. So what have we found so far? These are the results from the 2017 and 2018 batches. So far, for the 2 years, we had 73 applicants for the first two courses, and I have another 23 or 27 applicants for the third batch. Last two batches, we total graduated 30, we accepted 32 and graduated to 29 out of them. This current batch, as I said, 9 have been accepted that are ongoing. They have completed an FCPS with an average of 1.35 years after their graduation. It was from 10 different cities and 16 different institutions for the first 2 years. This year, the 9 different people also have participants from other countries. So one from Abu Dhabi and one from Saudi Arabia that are participating this year with these diverse background. I had applications from other countries like Ethiopia, Nigeria, one even from Bangladesh, but those participants were still residents in early phase in their training, and I thought it was not appropriate for them to join this course until they have completed their basic education in neurology or psychiatry or rehab or neurosurgery. I will accept any of these four, and maybe even internal medicine if they have some neurology background in future. On the whole, in the first 2 years, we showed a 30% improvement in their understanding of movement disorders, which is a very complex topic, from where they started to the end. And every single person who participated in these courses have improved. You can see this is a spread of the participants from the 2017 batch. Every single one is improving. Some are improving to almost more than double their initial performance, and others a little less. This is a spread of presentations and scores by one participant. So in 2017, 41 assignments, including quizzes, were submitted by a participant with their scores. Some of these zeros are their participation in the optional reading or discussion, where they didn't participate and they were not given any score for that participation. So I could track who is participating by how much and in what kind of assignments, and I can see what are interesting and catching to them and what are not interesting catching to them. So I take that feedback and I adopt. Sometimes I adopt within the ongoing course where I can change things and drop things which are not important or necessary. And sometimes I take the information from 1 year to the next year and change the course design. And I have learned to drop certain assignments which are not useful. I've learned to add new things that I found useful. So, for example, I've added these weekly tremor challenges that were new based on the interest from old cases. I've dropped the optional reading assignments, which I've seen that nobody wants to submit or majority don't want to submit, and that creates an imbalance with the other people. So I've kept the required reading assignment, but dropped the optional reading assignment. But this immense amount of information that I get and collect on these students allows me to know where the strengths of the course are and where the weaknesses are, what creates or translates into interest and engagement, what translates into success, and what does not. So I can adopt and change my teaching. So just in 1 year, this is data from 2018, there were nearly 9,000 page views online by these participants, so which is 22 page views per participant per week. Now you have to remember these participants were full trained neurologists. They had definitely a daytime job that they had to do. Many of them were also doing evening or weekend clinics. They are family people, most of them. They have kids. They had people getting sick in the 6 month. Someone's father got sick and they were falling behind. But despite all of this, despite having to earn a salary, have to have a family, have to have two jobs, they were still significantly engaged and they were still learning, which was an amazing result for me. So you can see the discussions from the 2018 course. The participation was at all levels. I had people who are recent graduates, I have people who are assistant professors, and I have even during my workshops and training courses, sometimes associate professors and full professors attend the course and want to participate and learn from the experience, because these are experiences which are designed to be better rather than just an open-ended lecture or seminar. Again, I've collected this information and presented my experiences to various platforms, including annual meeting of neurology and other platforms to share this experience, that how valuable this has been for us. And I've learned a lot of lessons from these. We do an end of course surveys where we take feedbacks from all of these participants on what they found useful, what their technological challenges were, how can we make the technology simple, how can we take away barriers. So for example, after the first course, I realized that people were having significant problem running the videos which I was recording. I could play them fine in my setup because I had high internet speed. I learned to lower the resolution of those videos and post them online, make them shorter, make the clip shorter so that they can play quickly and easily on people with all kind of bandwidth speed on their internet. So here's a summary of why this online blended learning can be very useful for targeted education for these short diploma courses or for skill-based learning. It provides a flexible environment where people can check on their assignments at night, going to bed, in the morning, in between their classes, on tea breaks, over the weekend. It creates a learning culture where people from various different places with similar interests are learning from each other, are teaching each other. There is intentionally designed content to achieve a certain objective. Each question, for example, in the quiz has been written to check a specific concept that I want to teach in that module. Similarly, each assignment has been designed to make certain task or objective achieved in a module. And then there is a professional educator, that there is a feedback that I'm giving directly to them on the patient videos, on the quizzes, on the reading assignments, on the summaries that they're submitting to me on how to do better. So flexible environment through observing and monitoring and different ways to learn the content and demonstrate their mastery. Learning culture by engaging in a meaningful activity through Slack, through online platform, Google Classroom, Canvas, and a self-paced learning. So you can watch lecture fast or slow. You can repeat the lecture as many times as you want. You can read the reading material as many times you want, rather than each one having to just catch everything in 1 hour. There is intentional content which I create and curate, which are relevant content for them that I intentionally select to achieve a certain specific concept. And then they are being regularly assessed for their grasp of content and interest, and they're getting formative assessments through tasks and activities such as concept maps, memory metrics, making of videos, and things, and so on and so forth. This is a summary of the project we did. I went through details in more relevant fashion, and letting you to think about how this can be useful, how this can be applied. I, of course, have more information I can share. I have information on their responses on the surveys that were done, what questions were asked. I have information on what does it correlate with, what correlates to a good performance at the end, what correlates to a bad performance at the end. But I kept all of this scholarship in education away from this presentation so that not everyone gets bored by the presentation and it remains relevant to a larger audience. But I'm happy to take questions now. You can also reach out to me on this email. And we are taking this concept now to create more courses. A stroke course is already on the way right now through APPNA Merit. There is a plan to create a general neurology course by University of Nebraska Medical Center for general practitioners or primary practitioners, which will be available online with CME credit, with a course completion certificate. And we're inviting other specialties such as cardiology, anesthesiology, family practice to create courses like these online to be offered to anyone who wants to have reach certain skills. Now, these courses of online, I don't expect them to replace the current learning system. They're not designed to replace the MBBS or residency. They're designed to complement the learning. They're designed to integrate. That's why we call them blended learning, integrate with the current online education during residency, face to face and bedside with the patient in the clinics, in the wards, complement the medical students' learning. And they complement by specific objectives that they reach a specific objective. Either it's teaching a subspecialty, it's teaching a skill, such as botulinum toxin injection techniques, such as deep brain stimulation surgery, or in cardiology and ultrasound for the heart, or echocardiography. So they're skill-based, they're practical, they're objective-driven, and they're complementing or blending the current ongoing learning or for people who are practicing physicians. So I'll stop here and I will see if there are any questions right now and invite the audience for those questions. Otherwise, feel free to reach out to me at any point in future.